Well, hello everyone, and welcome to this session of the AI Nurses Network webinar series. We've got a great nurse with us today, Dillon Dzikowicz from the University of Rochester in the US, who's going to talk to us about his research around AI and nursing. So, yeah, it'd be great to hear from you, Dillon, on what you're doing at the moment.
Sure. So thank you for having me again. A little bit about myself first, too, I think, because I'll give some context to what I do. Uh, I'm a nurse by background. I still practice, actually, per diem in cardiology on a telemetry unit. And I completed my PhD in addition to my undergraduate nursing degree. My PhD research is focused on ECG interpretation algorithms. So that's just a fancy way of saying those printout words or statements that you see on your 12-lead ECG. My research was really focused on the algorithms behind those statements and how we print out those statements. For my dissertation research was when I really actually got interested in AI. This was probably I graduated in 2023. So during that time, AI was becoming just more and more of a hot topic. So that was probably my first introduction really to AI and how to think about how you would use more dense computational modeling to achieve a better desirable outcome. At the moment, my research group is really focused on that exact problem. So our main kind of focus is detection of myocardial infarction, or colloquially known as heart attacks. There's a large number of heart attacks that occur what we call silently, so they don't appear as very obvious on the ECG. So we're using feature-based machine learning techniques to improve the sensitivity of computerized algorithms for the detection of these types of cases. And then secondarily, we're also really interested in arrhythmia monitoring. So this is thinking about wearables, thinking about patch-based devices, or ECG electrodes like on the chest for monitoring for things like atrial fibrillation or ventricular tachyarrhythmias. It's kind of my work at a high level of everything that we're currently interested in doing.
That's great. So, did you get some opportunities during your PhD to maybe learn a bit of machine learning and write your own algorithms? Is that kind of how it started?
It's really yeah. I never really took a formal AI class because, to be pretty honest with you, I was kind of trained in that, oh, don't worry about it. You're always going to have AI expert or computer scientist on a team, which I think is true. But definitely since I've graduated, I've learned to be able to talk better with a engineer. You need to have a basic understanding of that language. If I just go to the engineer and say, hey, here's my ECGs, build me an algorithm, they're not going to respond well because they're not going to know what you want. But if I can go in there and say, yep, here's my ECGs, this is my pre-processing pipeline, this is how I'm thinking about feature selection, and I want to use XGBoost or a logistic regression or one of these more explainable type models, and I can articulate that, then they understand, okay, this is kind of the general scheme, yeah, kind of achieve on that. So I would recommend to anyone listening to take a class or get in some depth experience, because I think having that knowledge base, not necessarily, I joke my students can code significantly faster than I can. What it takes me to do a day, they probably can do in an hour. But where most of my students are not nurses, believe it or not, a lot of them are physicians, doing an MD with a PhD, or they're in computer science or in engineering. They don't know how to read an ECG. They don't know the workflow that a lot of nurses do for ECG acquisition or patient monitoring. And those, I think, that is like our core, right? Like that is nursing 101. And I think that's why nurses bring so much value to these types of multidisciplinary teams.
Great. And how do you find getting data from the ECG machine? Do you collect your own data, or are there open access data sets you can use?
All of it. Yeah, all of
Ah.
it. So there's tons of open access now.
Oh, great.
And in addition to our medical center, I really worked with over the last year with our informatics team, and we have a whole research repository. So how we kind of built this is every ECG that's been done since the year 2000 to present day. We have a copy of it in a separate SQL database specifically for research purposes. So right now it's over 3.2 million ECGs.
Oh, wow, that's a really good data set to work from.
Yes. Yeah, exactly. Yep.
Yeah. I don't know how much you've mined the data, but do you know if there's any maybe certain groups of patients underrepresented in there, or yeah, that you're concerned about
100%.
it?
Yeah, so really, our first kind of focus has been to understand actually what we call physician phenotyping. So we want to understand in this whole database, we have nearly 300 physicians and advanced practice providers ordering and editing and interpreting ECGs in our database. And so the first question we're actually asking is, how do different types of physicians and APPs and advanced nurses interact with that database? And also, how does the care environment also influence why we're getting that ECG? And a classic use case, right, is a electrophysiologist is probably interested in a lot of different components of the ECG compared to emergency room nurse who's getting it because they're concerned for a STEMI. So we're able to look into that. And then our next part is exactly that. What we will actually do is merge this data set with our pediatric ECG data set, which is about 2 million ECGs. And then we can look at longitudinal over time. Specifically like patients who have Brugada or these rare types of cardiac abnormalities, congenital heart disease patients we have an interest in, epilepsy patients, where we have a collaborator in a neighboring university who's really interested in understanding the relationship of epilepsy and sudden cardiac death.
Great.
So yeah, it took over, I'd say, a year to go through all of the proper regulatory channels and IT and to do this. But I think right now it's like the most exciting part because it's coming together.
Yeah, it sounds great. Yeah, no, getting the data and cleaning it up and getting it ready is half the battle. And yeah.
Exactly. Yeah.
Great. Yeah, I'm wondering, do you have any advice for nurses who maybe are interested in AI, but maybe don't know a huge amount? What would be the best thing? I know every country is different, but what in the US could they do?
Yeah. How I really learned a lot about it is Coursera on YouTube. And for coding, I'll be honest, like LLM, ChatGPT, vibe coding type of
Oh, nice.
concept.
Yeah.
And GitHub. So GitHub is a really large code repository. People put everything and anything up on GitHub, and at least for me, it's always served as a good foundation. Like for ECG world, there's something known as ECG Deli. There's Braveheart. They're kind of like these, I call them like a base model. And then I've always just started there and then worked my way up to kind of customize what I was looking for at that time.
Okay, great. Yeah, there's loads of resources online for sure. It's
Lots of
just
resources.
trying to
Yep.
sift through the good stuff versus the not so great stuff, and
Yep, for sure.
getting your head around all the jargon. And I think like just learning all the medical jargon, once you get around that, and then it's not so awful to understand
Absolutely.
it.
Absolutely. Yep.
Great,
Yep.
great. I know this is a difficult question, but I'm always curious where you think AI might go in the future. I guess there's lots of, like you mentioned, vibe coding is now very popular and AI agents are coming on stream. Yeah, do you see nurses using these things in the future, or could there be other forms of AI that might arrive?
Yeah, I absolutely think so. I think specifically like where I live in the ECG algorithm space, I think what we will see is I call them like snippets of AI into these kind of more legacy interpretation algorithms. So so I'll give you a perfect example. Our heart attack detection. We know that the current algorithms out there for diagnosing and identifying STEMI really leave a big gap. I think what AI would do is really help supplement those existing guidelines that nurses and physicians already know, that AHA, ESC, professional bodies already endorse. And then AI kind of is used as a supplemental screening in addition to help rule in those cases that we've conventionally have always missed and has led to really poor outcomes. I'm still of the belief that I think that there's still going to be heavy user input and oversight, especially when we think about diagnostics, because of a few things. Of course, there's the clinical care, keeping the physician in the loop, liability, regulatory considerations as well. But that's kind of really for the ECG space, I see it. I think in other areas, I think like remote monitoring is going to be huge. I think the more that we can empower patients to be at home, I think it's better for patients. I think it's better for hospitals. I think it's better for clinicians. And I think how we're going to be able to do that at scale is only going to be through LLMs or these types of conversational bots, whatever you want to call them. I've seen so many different terms that they're used now. Because at least, in the US, we have a shrinking workforce. We have a constrained workforce and an exploding demand for care. So the question is always going to be, how can we do more with the same or less resources that we have today?
Yeah. There might be death by chatbot for a while, but I hope more sophisticated forms of AI might emerge as well that have maybe video where it's appropriate, or more kind of multimodal stuff.
Exactly. But I think that's where we even start. I mean, I think of heart failure as a great example because, we educate and train nurses through, undergraduate programs, for example. When you have a heart failure patient, right, you discharge your patient, what do you educate them on? Reduction in their salt intake, weigh yourself every day. If you gain more than 5 pounds in 2 days, call your doctor, right? Expect to double your diuretic. Look for signs and symptoms, right? Shortness of breath, weight gain, edema, swelling, etc., etc. I think all of that, I mean, how easy would it be that you capture that on a mobile app, right? And then you say, okay, my criteria, I have 10 questions. My criteria is if they answer more than 3, it sends a nurse an alert, and then an LLM automatically pops up to start asking more of those classic questions, right? In nursing education, right, we ask, when did it start? How severe, right? All these kind of questions that we already know. You could easily program a chatbot to already ask those. So by the time the nurse responds to that alert, they have a much broader clinical context. They call the patient, they make a clinical action.
That
how
initial,
do you do that
the initial kind of basic triage would be safe enough on the chatbot, hopefully.
Exactly. And then if you could demonstrate efficacy and effectiveness there, you just build and build on it. Integrate vital signs, wearables. We do a lot of research too with implantable devices like ICDs and pacemakers that are ever expanding, using newer technologies for both monitoring and thinking about other parameters that you can monitor from those devices. So I totally agree with you. I think that's kind of where you start, and then you just continue to scale and integrate multimodal components to better improve your accuracy, better decrease the number of false positives, etc.
Great. And if you got a big bag of cash tomorrow morning, what would you do with it in terms of AI research?
Believe it or not, implantables, I think, have implantable / wearables. That's where I see so much value. Again, I'll just I'll focus on ICDs as a perfect example. So Boston Scientific, for example, already has this type of heart failure measure of heart failure severity measure in their devices. And I think Some centers do a good job with it, some centers do not. But I think that's like a whole nother aspect of how can you take this really rich, continuous flowing data that the patient's not even thinking about and use that data to make really insightful clinical actions in the home environment to to really reduce things like readmission or hospitalization, or even urgent care and clinic care. Because I think that's the other interesting thing. We focus so much on the ED space, but then, I call my PCP and it's like 6 months to get an appointment. No one's talking about that, right?
Yikes.
How do you decompress even your clinic space and keep patients at home and engaged? That's where I would put, if I had $1 million, I'd really focus on that area.
Yeah, definitely more kind of preventative stuff before people really start to, end up in A&E or ED. That would be great.
Yep, exactly.
Yeah.
Exactly.
Great. And I know you're obviously quite busy doing research, but on the education side, do you get time to, I know you mentioned so you've got your own students, do you get time to teach nursing students about AI, or what are they doing at your university?
Yep. So I teach 2 courses primarily. The first is an ECG interpretation course. And there we talk, it's an undergraduate course. And there we're really kind of taking nursing students and really elevating their ECG interpretation skills. So many of my students already work or will be working in like a CV ICU, cardiac surgery, OR, so a cath lab where we do a lot of ECG monitoring. And there we can spend a bit of time going more in depth, talking both how to interpret rhythms, but also how to understand the algorithms that they interface with every day. And then the other course I primarily teach is a health technology course. So really, in that course, what we think about is EHR systems. What are they built for? How do you use them as a nurse? How are they built in the back end? And thinking about workflow design. So how can you customize, edit, modify these systems to improve workflow? And then how do you actually quantify that? Number of clicks, time on screen, time away from patient care. And how would you we kind of think through that on a project level for like quality improvement initiatives.
Yeah, they're all really important things to teach because they'll have a knock-on impact if they're starting using AI tools as well, how often they spend staring at the monitor.
Exactly. Yep, exactly. Exactly. Yep.
Great, great. Well, thanks so much. That's really interesting. And it's nice to see that you're, obviously have a really focused application of AI in cardiology nursing. Are there many nurses in the US doing that kind of research? I'm sure there's maybe pockets of people here and there.
Pockets of people. So I'm really fortunate. My mentor is actually another faculty member here at U of R, Mary Carey. Her mentor was Barbara Drew, who was probably one of the biggest PhD prepared nurses in patient monitoring. She was at UCSF. She's now retired. And then my dissertation committee included Michelle Pelter, who's now at UCSF, working actually on novel VT algorithms for patient monitoring. And then Wojciech Zariba was my other committee member, and his whole work has been on ICDs. He's a physician scientist. So to answer your question, I mean, that I know of, I think there's less than a dozen of us in the United States that are really focused on this area. I think that's a massive disservice. I think that's kind of why I get so excited about working in the Philips Medical Office, is because, to me, nurses are our primary end users of these algorithms, right? Of course, physicians look at the central monitor, right? Of course, the physician looks at the 12 lead, but the person who's typically acquiring that information is typically a nurse, right? They're typically the ones putting the leads on. They're typically the ones who print the ECG, definitely in ED or cardiology environments. So usually the first ones who are taking a look at it. In terms of bedside monitoring, I would say they're probably 90%, right, of the ones who are
Yeah,
actually interacting with the bedside monitor.
sure.
Um, and so I think it's critically important that in addition to physicians' input, that we get bedside nurse input as really these end users. So yeah, we're to answer your question, we're very, very small, but I hope by maintaining a faculty appointment and whatnot that um, it raises awareness and it raises helps prepare the next generation of nurse scientists who are really interested in physiological monitoring.
Yeah, and even for nurse practitioners, cardiology is
Yeah,
a huge area. So we definitely need more people skilled in that.
exactly,
Um,
exactly.
Great. Well, thanks so much for your time, Dylan. It'd be great to check back in maybe in 12 months' time or so to see how you're getting on and have a chat through some of your published research. I've just shared university profile
Sure,
on the call, but yeah, it'd be great to check in a while and see what's happening with AI in Rochester.
sounds great.
That's great. Lovely. Thanks so much.
Thank you.